regarding how the webs are evolving over time, we found in our study that these lesions are mostly stay stable over time and over a median follow-up time of 16.5 months. Only 8 out of the 83 patients in our cohort with multiple CTAs shows a considerable change in any of their morphologic feature, and that often presumed to be due to a superimposed thrombus. And so absence of morphologic changes in carotid webs may be helpful in diagnosis, in kind of may help improve the diagnostic confidence in distinguishing carotid webs from their mimics, such as atherosclerotic plaques and also dissections. And none of these patients with a considerable change in our cohort had a recurrent event due to carotid web. So we can't comment on that part in terms of risk of recurrence in those who had a considerable change. And the only morphologic feature that we found to be associated with the risk of a stroke was carotid web length. And one may say, so if we have a web that is increasing in size, especially in length, should be concerned? Well, maybe, but our study was not powered enough to detect such an effect and to kind of support this hypothesis. And this needs future research to investigate that further. So we categorized our patients to symptomatic webs versus asymptomatic ones. And symptomatic webs were the ones who had a stroke or TIA attributed to carotid web at the time of we identified those patients. And none of the patients who had a symptomatic carotid web, means incidentally found during other workups, had a recurrent event. So the recurrent rate in those patients were 0, but 3 out of 28 patients with a symptomatic carotid web had a recurrent event due to carotid web. And in terms of because patients had different follow-up time, the risk of recurrent due to carotid web was about 6% per 100 patient years, versus 0 in the asymptomatic group. And thus, we don't recommend any intervention for the asymptomatic carotid webs based on the current data. Regarding the risk of recurrence in the symptomatic carotid webs and how we should approach those patients in terms of secondary stroke prevention, we don't have clinical trial data to come up with a firm recommendation for sure, but as we observed in our cohort and in line with previous literature, the risk of recurrence in these patients is pretty high, and the observational data showed that carotid artery interventions such as carotid artery stenting or endarterectomy was associated with 0 risk of recurrence. But on the other hand, using antithrombotic treatment was associated with recurrent events in these patients. And in our we discussed our research between our stroke physicians at Penn, and physicians were more inclined nowadays to use carotid artery intervention in those with symptomatic carotid webs. And in our cohort, those 3 patients who had a recurrent event, one was on single antiplatelet, one on DAPT, and the other was on anticoagulant. I think with the current literature, we can say it might be reasonable to go with carotid artery intervention for those who had a symptomatic carotid webs, but not the asymptomatic ones.